Okay, a little bit more on pulmonary blood flow. The circulation of deoxygenated blood from the right ventricle through the pulmonary arteries to the lungs for gas exchange, returning oxygenated blood to the left atrium. With blood flow, gravity is a significant impact, just in the aspect of the hydrostatic pressure gradient, meaning that the lung bases require more blood flow and more oxygenation than the upper, which is the apex. So there is more vasculature, more of the oxygen exchange going on in the lower parts of our lungs than in the upper parts. Um, and then hydrostatic pressure gravity creates a negative 15 mmHg in the apex compared to a positive mmHg base in our bases of our lungs. The pulmonary vascular resistance calculation is PVR equals PAP minus PCWP divided by QT, which PAP means for pulmonary artery pressure. And that is the pressure in our pulmonary artery and how much it's like needing to be able to move that blood volume or flow through like the cylinder, which is our arteries. Our PCWP is our pulmonary capillary wedge pressure. And that is taken when a physician puts in this catheter. And all these numbers are measured through a procedure where they put a catheter in. It goes up into your right atrium, down your right ventricle, up into your pulmonary vein or artery. And it just kind of inflates a little balloon, and that's where they will get that measurement from. That'll kind of measure how much, once again, how much pressure or how much force is needed to go through to move that blood flow. And then cardiac output is pretty much how much we get in return that is getting moved oxygen-rich blood into our system. Our pulmonary vascular resistance normal values are in dynes. So dynes per centimeter. Normally it's between 20 to 130 dynes per centimeter, but some sources have cited up to 250. So that's just a little bit of range of numbers there. Pucelli's law. So Pucelli's law is just a law that Pucelli made because he discovered it. So it just measures the distance between like point A to point B in a cylindrical pipe, which is what it's kind of referring to our arteries and our veins, because they are, pushing blood flow from one side to the other, from our right side of our heart to our left side of our heart. Here's the calculation for that. And then next, we are going to talk about our zones. So our lungs are divided in 3 zones. Our first zone is zone 1, and that is at the upper part of our lungs, which is our apex. Our zone 2 is like our middle part of our lungs, and then our zone 3 is the base of our lungs. So in zone 1, the alveoli are overextended, which it kind of depicts on this picture right here. And I'm not an artist, so I tried my best. So here our little alveoli, which is like a little grape on a stem, is overextended. Most of the time, this is at its highest point of oxygenation. So our PaO2 is at our max, somewhere around, I think, 130 mmHg. So our pulmonary alveolar pressure is higher than our PA, arterial, and then our PV, which is our venous. So it's not getting a lot of gas exchange just because our little alveoli is crushing down our little capillary. So there's not a lot of perfusion and gas exchange happening. In zone 2, there's a little bit of a gray line just because in the upper part of zone 2, it kind of follows zone 1, where the alveoli are still a little bit more overextended and our capillaries are still a little bit more flattened out. But as you work your way down closer to the base, as you know, gravity helps, and gravity has a big effect on that. The alveoli are starting to get a little bit less overinflated, And our capillaries are opening up a little bit, so they are able to do more gas exchange. So here, especially towards closer to zone 3, our PA, which is our arterial, is a little higher than our alveolar and then our venous. So there's a little bit more gas exchange happening. And then in our zone 3, which is where a lot of our gas exchange happens, the alveoli and the arteries are equally extended, allowing proper maximal gas exchange and perfusion. So down here, our blood flow is at its highest just because there's nothing being constricted, nothing being over distended, and our alveolar ventilation is higher because everything is getting crossed from one side of the permeable membrane to the other. Our CO2 is at our highest point just because there is a lot of gas exchange. So a lot of our CO2 are going out and then oxygen is coming in. So yes, so that explains our base lungs. And then, okay, things that determine a lot of our cardiac output. It's our heart rate and our stroke volume. So it's just, how much our heart is working. Our heart is a muscle. So our myocardial contractility is a strength and force of which where our heart has to be able to squeeze and then kind of relax so that it can fill and eject the blood through the body. It is increased by higher calcium levels. Increased heart rate, increased preload, hormones such as like our thyroid. Our thyroid. And then it is also increased by inotropic agents. Those drugs can be like catecholamines, like epi, noriepi, dopamine, dobutamine. Digoxin inhibits. So that is one of the decreased ones. It is by a parasympathetic stimulation, which our parasympathetic stimulation is like a vagal maneuver when we kind of like bear down. So that kind of brings down our heart rate, which brings down our cardiac output a little bit. So like when we tell patients, can you just bear down a little bit? It may be just to kind of help them bring down their heart rate down a little bit if it was too accelerated. Medications that would bring down our myocardial contractility include beta blockers because they affect the sympathetic stimulation into our sympathetic system, calcium channel blockers, and then anti-arrhythmics that just kind of bring down our cardiac output, our heart rate, which is not squeezing as much. Pathological problems are like ischemia, infarction, like a heart attack. Those obviously affect the way that our heart works. So which allowing less like a reduced function, and then myocardial inflammation. Obviously, if there's something going on with the heart's not going to be able to squeeze and contract and fill as it normally would. And then metabolic abnormalities, hypoxia, there's a low oxygen supply. Acidosis is one of those. With low pH, it reduces calcium, so then the heart is not able to contract as much. And the calcium is not able to bind to troponin. Hypercapnia, it's just increased levels of CO2. So if there's a lot of CO2, the heart is not able to, the heart is, going too fast or going too slow, and there's not enough gas exchange. So our CO2 is building up in our body, and then our heart is not functioning properly. And then electrolyte balances, such as like hypercalcemia and increased levels of calcium. Our preload is the degree of the ventricular myocardial stretch at the end of diastole, which is commonly measured at the end of diastolic volume or pressure. Increased by higher venous return, increased blood volume, skeletal volume pump, and atrial contraction or a slower heart rate, longer filling time. Decreased by reduced venous return, hemorrhage, dehydration, rapid heart rate. When our heart is beating super fast, it doesn't have enough time to fill, so there's not a lot of gas exchange going on with the blood that does go into our lungs, which can cause our CO2 to go up and our O2 to come down. atrial fibrillation, and loss of atrial kick. So our heart is not moving as fast. Afterload is the pressure of resistance the ventricles must overcome to eject the blood that goes through. This is measured as the systole terminus by the systemic vascular resistance, aortic pressure, aortic valve integrity, and blood viscosity. Increased by hypertension, vasoconstriction, aortic stenosis, and increased blood viscosity. It is decreased by vasodilation and hypotension. So if their blood pressure is too low, or if their arteries and veins are too dilated, there is not enough force or stroke volume to like move that blood through. Okay.